So firstly, just to reiterate Jennifer's points about epidemiology. So really, this slide illustrates that the people who have high rates of hepatitis B occur in certain parts of the world, and WHO divides this into high, intermediate and low level of prevalence. And you can see that Australia in blue is technically a low prevalence area with roughly a prevalence of about 1% of the population. However, as I would show you, that there are subgroups within the Australian population that have much higher rates of Hep C. And in reality, the people that we will be diagnosing and treatment really come from those pink areas. So they were usually born overseas. Next slide, please. So the distribution of Hep B is shown here according to who has it in Australia. And what you can see is it reflects overseas born people. As Jennifer said, these are patients who really acquired this very early in their life. They got it either perinatally at the time they were being born or early horizontal transmission very soon afterwards. So the majority of people were born in areas of high endemicity. And you can see that, 33% of people were born in Southeast Asia, 16% Northeast Asia. So almost 50% were born overseas. Not to forget that Indigenous Australians are highly represented. So 16% of cases of Hep B in Australia are Indigenous Australians, and that is important, particularly in an area like Mildura. Importantly, IDUs and MSNs really represent only a very small percentage of our cases, but they are there. Next slide, please. All right, let's move to natural history and how this disease pans out. And at the very beginning, what I need to tell you is that the thing that underpins how this disease pans out is the patient's immune system. That'll be key all the way through. So this is what happens at infection according to age. And it tells you why being infected at birth is such an important issue. So if you look at the rates of chronic infection, if you get infected at birth, your likelihood of getting chronic infection is 90%. It's very, very high. But if you look at the green line, you almost never get sick. And the reason is your immune system doesn't clear the infection because it's immature. As you get older, beyond 12 months of age, those things cross over. By the time you're an adult, your likelihood of chronic infection is probably less than 5%. It's actually very unusual to get chronic infection by the time you're an adult, but you actually get sick. And that is because the immune system makes you sick. And you can see in the green line, by the time you're an adult, you have a 40% chance of having acute hepatitis. So you can get jaundice and occasionally you can get liver failure from this. The number one, the outcome of the infection is determined by the immune system and age, which are interlinked. Next slide, please. This is a slide that usually makes people's eyes water over. So this is one of the things that's a bugbear for a lot of people in the hepatitis B serology. And unless you do this all the time, it's one of those things you learn quickly. So let me at least try and walk you through and just remind you of what the different serologies are. Hepatitis B surface antigen is probably the most important marker because it tells you that that person is currently infected, and by definition, if it's there for over 6 months, it defines chronic hepatitis B. Okay? Surface antibody is notes immunity to infection, and it's immunity that is protective against infection. So it can be positive in patients who have been previously infected or patients that are vaccinated, because surface antigen is in vaccine. E-antigen is another marker that, and we'll talk about that in a minute, that indicates very high levels of replication and infectivity. E-antibody is not a protective antibody. It means that that level of infectivity and infection has come down, but it is not a marker of inactive disease. And we'll go through that in the next slide. Core antibody is not a protective antibody, not a component of vaccine. So if you have core antibody, it means you have previously been infected by the virus. And the way you tell whether someone whose surface antibody positive has been naturally infected or vaccinated is if they have core antibodies that are naturally infected. Remember, people get confused about core antigen. Core antigen does not occur in the blood. It's only in the liver. So please don't order it. Okay. Next slide. And this is what happens with acute infection. So remember, some people, we still see people who get jaundice and really sick with really high liver function tests. And that's because they've acquired recent hepatitis B and they get sick, and they're the 40% that get an acute infection. And you can see what happens there is that you get surface antigen going up, then you get core antibody going up, and then they resolve the infection in 95% of cases, and they form surface antibodies and core antibodies in the initial time. So the majority of people with acute hepatitis B actually get better. 1% go on to have formative hepatitis B and get really sick, and they may die or require liver transplant, but the majority of people get better. The right-hand panel is what happens if you develop chronic hepatitis B. That means your surface antigen positive for 6 months in the past. So obviously the surface antigen doesn't go down, it stays up, and then your core antibody stays up. And there's a marker called core IgM, which goes down. And core IgM can be used, if you look at the left-hand panel, between surface antigen and surface antibody. And in acute infection, the core IgM may be the only marker that's positive and make a diagnosis. Okay, next slide, please. And this is what happens if you become chronically infected and there's no treatment. So we've talked about acute infection and the progression to chronic disease. Now, if you have chronic infection, about 30% of those patients over a lifetime, 30% of those patients over a lifetime will develop cirrhosis. That's quite a lot. If you have cirrhosis, you then have about a 23%, well, roughly a quarter of a chance of developing liver failure. So you decompensate, at which point you made a liver transplant or you died, depending on where you live. The other thing is that about 5 to 10% of chronically infected hepatitis B individuals actually develop liver cancer. Most of those have cirrhosis, but not all of them. So overall, if you put this all together, there is a 25% lifetime mortality if someone remains untreated, which really highlights the point of diagnosing these patients, getting them into care and treating them if they qualify for treatment. So you can see the consequences of not doing this. Next slide, please. And the other thing that we deal with is the different phases of chronic hepatitis B. So let me just walk you through this because it's not straightforward. So the phases are really divided up into, and again, the key to this is the immune system. Really 4 major phases and then a 5th if you actually resolve the infection. And they're based upon your Hep B viral load or the Hep B DNA, the liver function test, and your e antigen status. And they're phases 1 to 4. And I still use the old terminology because the word immune underpins them and tells you what's going on. So phase 1 is kind of the first 15 to 40 years of a patient's life if they're chronically infected. So remember, we're talking about chronically infected people who are surface antigen positive. And these individuals have what we call the immune tolerant phase. And the reason we call that term is because there's a lot of virus around and their immune system is not fighting it. And the issue is the immune system fighting the virus is actually what makes you sick, not the virus itself. So for the first 15 or 40 years of a person's life, you'll see they've got very high levels of DNA, their liver function is normal, and they are e antigen positive, that marker of high replication that I talked about. What then happens is that the body breaks that immune tolerance and the immune system starts to fight the virus. And you enter a phase called the immune clearance phase. And simplistically, the way to think about it is your body's or your immune system's attempt to drive that level of replication down. So under those circumstances, the immune system starts to fight the virus and the liver function tests go up. Again, indicating that it's the immune system fighting the virus that causes the damage. If it's successful, you enter the immune control phase. And the immune control phase is such that the DNA comes down and it'll be low level or negative. It isn't always completely negative, but it'll be certainly below 2,000 international units. Your liver function normalizes and you e-antigen seroconverts. So you lose the antigen and you gain the antibody. And this is what we call the immune control phase, because in essence, your immune system is controlling the virus. And in reality, most of the patients we diagnose are in this phase. The virus is smart. What then might happen is that the virus has mutations that escapes the immune system. So that what then happens, the DNA goes back up, the ALT goes back up, and they still remain e-antibody negative, e-antibody positive, e-antigen negative. And that phase obviously is called the immune escape phase. And what you will see is that treatment for the most part, and there are a couple of exceptions I'll talk about later in the talk, when the ALT is up. So it'll be in phase 2, the immune clearance phase, or phase 4, the immune escape phase. If you are lucky, you will actually lose surface antigen, in which case you will enter a phase that we call resolved hepatitis B. You may or may not develop surface antibodies in that context. That doesn't happen very often. It happens at about 1% per year, and it's irrelevant whether you're on antiviral treatment with a nucleoside analog or whether you're not. It's still about 1% per year. Now, over 50 years, that'll accumulate, but it just doesn't happen very frequently. Next slide, please. And one of the key things that we need to actually monitor this virus is a Hep B viral load, which is now reimbursed by Medicare. And we express this in international units to standardize the different assays. And what you can see is this is really incredibly sensitive. So a bit like HIV and Hep C assays, the low limit of detection is now 10 to 20 international units per ml, which is exquisitely sensitive. Now, if you are ordering this test, you need to be careful you don't order it too often in an inappropriate situation. So what you're allowed to do under Medicare, if you are not on treatment and you're just monitoring that patient, you're only allowed 1 test a year. If you do that early, patient will get a bill. So you just need to be careful, right? If you're on antiviral therapy, you can order 4 of those tests a year. So that's fine. Next slide, please. All right, let me now, I've set the scene, let me move to therapy and what we have available and how we manage these patients. All right, so the qualification for treatment is as follows. This is the Medicare working. So to qualify hepatitis treatment, you need to have an elevated viral load and an e-antigen positive. This needs to be greater than 20,000 international units. If you're e-antigen negative, i.e. in the immune escape phase, you have to be greater than 2,000. And you have to have documented chronic hepatitis B infection, and you need to have evidence of liver injury. Technically, the wording says an elevated ALT or a liver biopsy, but in essence, no one does liver biopsies these days anyway. So it essentially means a high viral load and an elevated ALT. If a patient is cirrhotic, the viral load estimates don't count and you can treat at any viral load, okay? However, if they're cirrhotic, we should probably see those patients because they're more complex. It requires an authority prescription, which is a streamlined authority, and it doesn't cover special populations such as immunosuppressed patients, and I'll talk about those later. It does now cover pregnancy, and I'll talk about that in a little while. Next slide, please. All right, so what are the drugs that we have available? This is the list of total drugs to treat hepatitis B, and they're much smaller than the drugs, for example, for the treatment of HIV. So like was mentioned earlier, we used to use interferons for the treatment of hepatitis C. In the old days, that was the only treatment we had for hepatitis B as well. We virtually hardly ever use it. We do occasionally, but I'm really going to focus on the 2 main drugs that we do use. So the other group of drugs are the nucleotide analogues. And the 2 drugs that we use are entecavir and tenofovir. And those are the ones I'll focus on because they're the ones in common use. Lamivudine was the first oral agent to be used earlier on, but as I'll show you later, it had problems with drug resistance, so it doesn't get used, certainly not in an Australian setting anymore. Next slide, please. And the issue is that these are highly effective drugs. So this tells you over a 5-year follow-up period, the rates of suppression with both these drugs, and they're incredibly effective. And you can see that over a 5-year period, you get 94 to 99% suppression, regardless of which drug you use. And these are not head-to-head comparisons. So these two drugs are regarded as similar in terms of their viral load reduction. And you can see if you're E antigen positive in blue, you take longer to get there because you start from a high viral load. E antigen positive patients have a higher viral load than E antigen negative patients. But the point is that it reads, as long as the patient takes their drug, it'll lead to suppression in nearly all those patients. So they're highly effective drugs. Next slide, please. The other question patients will, and some doctors and other health practitioners will ask you, well, when can I stop my drugs? And it's not a straightforward question. So there are endpoints that we use to stop drugs, and it depends whether you're E antigen positive or E antigen negative. So if you are E antigen positive, you usually have very mild liver disease, and what you may be able to do is stop that drug if you E antigen seroconvert and you actually enter the immune control phase. And this is the rate of E antigen seroconversion over a 1-year period with all drugs, and they're all about the same. The sort of 20 to 25% are over a 1-year period. Next slide, please. However, as time goes on, it goes up and up, and you can see by the time you get to 5 years, there's about a 50% E antigen seroconversion rate. So what happens is that if you E antigen seroconvert over a 12-month period, so you're E antigen negative, antibody positive, and that's confirmed over 12 months, you can discuss with that patient to potentially stop their drug. The problem is that there is a relapse rate and you need to monitor that. So the relapse rate is about 50%, but a lot of patients will be keen to stop their drug, so you can have that conversation. Next slide, please. The other issue is, and before I move on, in E antigen negative patients, we do not, because the relapse rate is very high. It's about 70%. So we generally, and they're often got more severe liver disease, so we don't. There are studies looking at this, but it's not something we would routinely do. Generally, those patients are on for very long periods of time unless they S antigen seroconvert. If they S antigen seroconvert, you can stop. Okay, the other issue is the issue of resistance. So anytime we use an antiviral, we're concerned about the development of antiviral resistance. And what you can see is that the two drugs that we use have incredibly low rates of resistance. If you look back at Lamivudine, which is the original oral drug we used, after a 5-year period, 70% of patients were resistant to it, which is why we don't use the drug anymore. If you look at Effectiv, the third last on the bottom panel, it's 1.2% and doesn't go up with ongoing time. It's just flat. Tenofovir still has no resistance, which as a person with a virological background is stunning that a single drug would do this, but the data is there. Okay, so these drugs are associated with incredibly low or no levels of resistance. Next slide, please. This is what I'm talking about, long-term therapy. So let me reiterate, if you are E antigen negative, your rate of staying negative on follow-up is only about 30%. And remember, E antigen negative is further along the natural history, so they will often have more liver disease. In general, we do not stop medication in this situation. If you're E positive, it's about 50% and they have mild liver disease. So it's possible to stop, but you need to watch those patients very carefully. Okay, next slide, please. So what do these drugs do? So clearly they suppress hepatitis B DNA highly effectively. They normalise your ALT. They'll prevent fibrosis progression, but not only that, they will actually promote regression. So they'll make scarring in the liver better. We used to think that scarring in the liver was a fixed process and it never changed, particularly with cirrhosis. We know that that's no longer the case. You can actually move back, even if you're cirrhotic, and I'll show you data of that in a second. It even reverses patients with liver failure. If you start someone with liver failure with hepatitis B, put them on a drug, they'll actually get better. It reduces, but it doesn't eliminate the risk of HCC. And we'll talk about that in a moment. But one of the issues, as Jennifer told you, is that HCC is a big issue in Hep C. So one of the things we'll do, and again, I'll show you a slide on this, is that we screen appropriate patients for HCC. And if you are on drug, you still need to screen those patients. It doesn't stop that, the need to do that. So long-term therapy is effective, but the issue is low rates of surface antigen loss are low. So that's why you will not be able to stop medication in a lot of these patients. Next slide, please. And this is the slide that tells you that patients actually move backwards and improve their fibrosis. So this is data at baseline, and if you look at the year 5, the ESAC fibrosis score is the amount of scarring, and 6 is cirrhosis, right? So if you look at patients with an ESAC score of 4 or greater, meaning they have a lot of scarring, at 5 years, when you use tenofovir, which is one of the drugs we use, it goes from 8% at baseline down to 12% at year 5. So there's a marked improvement. And if you just look at the cirrhotic patients, which are the green, 28% at baseline down to 8% at year 5. Which shows you that if you do paired biopsies, not that we do that on a regular basis, but this was a clinical trial, that even cirrhotic patients will improve. Next slide, please. So this is the HCC slide, and as Jennifer told you, HCC is a major issue, and one of the things that we need to do when we manage HCC, and that is not done very well at all, even by us specialists, is that we need to screen patients for liver cancer. And if you're going to do this properly, the data suggests that you need to do it every 6 months, not 12 months, and that you need to do it with at least an ultrasound and perhaps an alpha-fetoprotein. So whether you use an alpha-fetoprotein is arguable. Some people do, some people don't, but at least an ultrasound. And obviously that arrow is pointing to an HCC in the liver of a patient. So who do we screen? We screen all patients with cirrhosis. We'll screen anyone with a first order family history, so brothers, sisters, father, mother. And then it depends on your ethnicity and age. So in Asian people, we screen all males over the age of 40, females over the age of 50, and in African individuals, it's anyone over the age of 20, because people from Africa have a higher rate and earlier onset of HCC. And in Australia, we're also screening Indigenous individuals over the age of 50 because their rate of HCC goes up. And this is probably one of the worst things that all of us do. Okay, next slide, please. All right, let me switch gears and sort of, the last speaker set the scene really nicely on this, and that is hepatitis B management in pregnancy, because that's changed over recent times, in particular with the advent of the use of antivirals to prevent mother-to-child transmission. Okay, so as you were told, any child born to a surface antigen positive mother automatically gets HBeAg and their first dose of vaccine early post-delivery, ideally within 12 hours of birth, and then gets a full vaccination course. What is apparent is that some mothers still have transmission to their babies despite that. So it's 95% effective, but it's not 100% effective. So the question is, who is at risk of transmission? And the answer is early in around 2009, that this publication came out from a Sydney group, which showed that mothers who are antigen positive had a 6.6% chance of transmission to their babies. And then it became apparently the antigen was just a surrogate marker for Hep B viral load. So it was your viral load that really mattered. And you can see that if you're over 8 log copies per ml, you have an 8.5% chance of transmission to your baby. That's significant in the setting of someone that's had vaccine and HB. Next slide, please. And then there was a Chinese study that really sort of tried to tease out where that viral load threshold was. And what they found was that it was 6 log 10 copies. And if you convert that to international units, it ends up being 200,000 international units. So the threshold of transmission looked like it was 200,000 international units, which is based on that, which is why that became the threshold at which antiviral therapy started to be looked at. Next slide, please. And this is the pivotal study that really nailed tenofovir as a significant drug to be used in this setting. So this was a study that was a multi-center study in 200 pregnant women who were e-antigen positive and had a DNA greater than 200,000 international units. And they were randomized to standard of care, which was obviously HBeAg vaccine. You have to do that. And then tenofovir from 30 to 32 weeks up until 4 weeks post-delivery. And then they were followed up. So next slide, please. And here's the money slide. And particularly look at the left, because a per protocol analysis are the women that actually took the drug for the whole time. And if you take your tenofovir for that period of time, you don't have any transmission, whereas there's 5.16% of individuals in the standard of care group. And what's happened now is of recent times, this has now come on Medicare. So you can start tenofovir in the 3rd trimester of pregnancy in high viral load women, purely for the prevention of mother-to-child transmission, separate for the other indications that we talked about. So that is now standard of care. Next slide, please. The other setting where the regular medical rules don't apply is reactivation and immunosuppression. And I guess you guys won't be dealing with much, but it's become a hot topic as well recently. Remember, the immune system is what controls this virus. So next slide, please. And what happens is that if you're in the, for example, in the immune control phase, your immune system is in a balance with the virus, it's controlling it, you're still surface antigen positive if you have a low viral load and your liver function is normal and you just tick along. What happens if your immune system is damaged or if you undergo therapy to decrease its effectiveness is that that balance is upset and the balance is able, and the virus is able to reactivate. And that happens particularly with treatment. So if you undergo chemotherapy, if you have an autoimmune disease and you need steroids or other therapies, then things change. So next slide, please. And this is what happens. So you're in the immune control phase, you know you've got a low viral load or an undetectable viral load, normal ALT, and but you're still surface antigen positive and you're e-antigen negative, e-antibody positive. In you go with immunosuppression, that balance is tipped. And then your viral load goes up. And after that, after a lag period, your ALT goes up. And sometimes it goes up a lot, as I'll show you in a moment. And you can even go all the way back to antigen positivity. Next slide, please. And this was first shown, and this is just one early example that really illustrated the point. So this is published way back in the early 90s. And it was in 100 patients who had lymphoma who were given very high level chemotherapy called CHOP, which is used for non-Hodgkin's lymphoma. When they looked at the 27 surface antigen positive patients, what they saw was that almost half of them reactivated. A quarter of them became jaundiced. 4 of them had non-fatal liver failure and 4 of them died. And we still occasionally see deaths with chemotherapy because patients are missed with this. And it tells you what happens if you don't get this right. Next slide, please. So obviously the next step is, well, can you give antiviral therapy as prophylaxis to prevent this happening? And this is a large systematic analysis looking at, in the early days, Lamivudine. We don't use Lamivudine these days, but it illustrates the point that you can markedly reduce the rate of reactivation and liver failure with antiviral prophylaxis. The problem is this is still not on the PBS, and there's been a lot of work to try and get it there, but it clearly needs to be there. But these patients are now routinely treated, but they're treated with either entecavir or less commonly tenofovir. Next slide, please. Next slide, please. Finally, the other thing I'd like to tell you about is Delta virus, which is hepatitis D. And hepatitis B is a deficient virus that essentially only exists in the presence of hepatitis B. So hence why it's in the hepatitis B talk. It cannot exist unless you happen to be surface antigen positive as well. You need the surface antigen for Delta virus to replicate. Next slide. And the work in Australia suggests that just under 5% of our population is Delta co-infected, which means that you really need to look for it. And again, this is one of the things we don't do very well. And Delta will do two things. If you get the two viruses together, you can either get the two viruses at the same time, B and D, and you get a more severe acute hepatitis. But if you survive it, which most patients do, then you'll get spontaneous clearance of more virus. The common situation is that you're already surface antigen positive and you get Delta on top of it. And it usually results in persistent Delta viral replication. And what happens is you get faster progression to cirrhosis and a higher rate of HCC. So it causes more severe chronic and acute liver disease. Next slide, please. So again, roughly just under 5% of patients are Delta antibody positive. Screening in surface antigen positive patients is poorly done, even by us. So if you see a surface antigen positive patient, the recommendation is you screen for Delta antibody, not antigen because it's nowhere near as accurate, but you screen for a Delta antibody. And if it's positive, you do a Hep C RNA, which is the genetic material of that virus. The problem is the treatment for Delta, if you need to go down the path of treatment, is incredibly difficult, and it's probably beyond the scope of our discussions today. But I think it's something we should at least do to identify those patients. Next slide, please. Okay, so the final point I want to make is we're sort of changing what we're looking at as a goal of therapy. Previously, we were focused on suppressing the virus and keeping patients out of trouble and improving them. We do that really well. Those drugs are great. What we can't do at the moment is cure that patient. So the latest advances in hepatitis B are aiming at some sort of cure. They're sort of paralleling what's going on in the hepatitis and the HIV literature and sphere. If you talk about cure, cure is not as simple as you think it is. There are two types of cure. One is true sterilizing cure, sterilizing cure where you basically remove every remnant of that virus from the liver. At the moment, that means that you have to remove an entity called cccDNA, which is a mini chromosome, which is incredibly resistant to antiviral therapy. That currently is extremely difficult and for the moment is a bridge too far. What we can do, however, is look towards a functional cure. And remember, I told you that about 1% per year of patients lose surface antigen. That is what we define as a functional cure. That is much more realistic. So what we aim to do, and this is where the current research and new therapies are heading towards, is we're looking to achieve an S antigen loss, ideally with surface antibody acquisition, but not necessarily, at least an S antigen loss. And what you may be able to do is actually stop therapy in those patients, unless they're cirrhotic, obviously. Next slide, please. So the bottom line is that cure is not so simple, and the reasons lie in the virology, and next slide, please, Elaine. So there's been an absolute explosion in new targets for hepatitis B, which are now in development. So they're in early stage development, sort of phase 1 moving to stage 2. So they're not that far away. And the cure targets are basically based on two different approaches. One, you want to reduce the viral burden, and there are a whole different bunch of targets available. In particular, these group of compounds here, the interference RNA inhibitors, drop surface antigen. And what we're learning is that surface antigen drop is a currency of what makes it more likely for you to lose surface antigen. And the other way of approaching is to stimulate host immunity, including, say, anti-cancer drugs like PD-1 inhibitors. but there are a whole host of other immunologically stimulants agents. And what will almost certainly need to happen is that you need to combine those two approaches, and hopefully we can get towards what we're calling a functional cure. And this is where the field is heading at the moment. Next slide, please. So the reality is that a successful approach for a functional cure will almost certainly require a combination therapy approach, not just one drugs. It sort of started about 5 years ago, and it's gaining steam, and we're starting to combine these drugs, and hopefully in 5 to 10 years, I can stand here and say, this is a combination we need to cure this patient and help them lose surface antigen. So this is the future. Next slide, please. Finally, referral pathways. So this is our team. Kumar's on the right, I'm obviously on the left, and the real person that does the hard work is Yaz, who's in the middle, who's in this room. So we conduct infectious diseases clinic at Sunraysia Community Health Service. Our focus is on viral hepatitis in particular, because there was a need for it that wasn't here when we first started doing this 10 years ago. We do other infectious disease. We treat HIV, TB, a whole bunch of stuff, whatever comes up. We do a combination of face-to-face visits and telehealth. We physically come up every 3 months, and we'll do a telehealth roughly every month. So every month there is some patient contact. Yaz, who's sitting at the back of the room, is really the key to this and coordinates everything. Has been a fantastic resource for us. And I need to sort of give acknowledgement to her predecessor, Dale, who was also fantastic in that role. If you want to provide referrals, patients can self-refer. We can get a referral made by Kalichi, the doctor at Sunraysia Community Health, or through other medical professionals. And the contact details in there, and we can provide you those down the track.